Guys, welcome back to Medical Coding with Blue. Today's episode is all about medical coders. How long should you stay in a specialty before moving on? If you are brand new to my channel, welcome. I am Blue. I'm a medical coder. Okay, guys. So first things first, I got this question and we're going to do the episode about it. I'm going to read the comment here in a minute, but I want to say this first, a little bit of housekeeping first. I love questions. I love thoughtful questions from the audience, but know this, okay? This whole show, me, the whole thing, from comments to the videos to the uploads to the thumbnails, everything is on me, okay? I run the whole thing. So when I respond to you, when I respond to your comment, it's because it's like right there in real time, and I got you, okay? I got you. I write things down. I keep a notebook with me that helps me to remember like show ideas and things like that. And I try to film ahead of time because I have a lot of things going on. And so I try to make sure that I balance my time. And part of that is scheduling the uploads, getting them all uploaded and things like that. So I've been trying to do that the last couple of weeks. So when I respond to your request for a show topic, or if you ask a question and I say I'm going to do a topic about that in a show, believe me, okay? You don't have to ask me again, because repeated questions like that, repeated the same thing, kind of gets to me because I already told you, okay? So just ask me once, guys. Just ask me once. And if I respond to you, that's exactly, what I'm going to do, okay? So just be patient with me, all right? Because again, it is all me. I have no assistant. There's nobody to help me with the comments. I do all of that myself too. Emails all day long. All day long. My phone gets messages 24/7. So just want to let everybody know that it is just me. So if I respond to your request, I will get to you. Okay, so here's the comment. This is, hello Blue. What is your advice about how long a person should stay working in one specialty when starting out as a new coder prior to moving on to another specialty? Or should you continue learning in that specialty that you are working in prior to learning a new specialty? So I've always said that you always want to get a variety of experience. Sometimes new coders, especially new coders, will get started in a particular specialty and they'll get really good at it. And then they don't want to move because now they've gotten confidence and they know kind of what they want to do, and they understand those codes forward and backwards for that particular specialty. So they really don't want to try and to go to other places. So say, for example, you started off in physical therapy, right? You started off as a coder in physical therapy, and now they need your help over in the ER. And you are just like pumping the brakes because you don't want to go to the ER because you don't know anything about those codes. Well, you should always want to be well-rounded as a medical coder. The best way to be well-rounded is to actually move, as far as move and volunteer to be cross-trained for other specialties, because that's only going to help you alleviate that fear of the really difficult work, or specialties that are a little bit more challenging. They won't scare you because you are so ready to try these new things. There's really no prescribed amount of time that you should stay with a specialty. Obviously, you want to be good at the specialty before you move on, but every day is a learning process. And so because every day is a learning process, you want to make sure that you are learning as you go, and whatever specialty that you land in, you want to make sure that you're doing a Google search about that particular specialty. So if I was to get into the cardio clinic, I would immediately go to the American Heart Association so that I can start to understand the anatomy, the pathophysiology for all of those things. Even though I've got that down, I still need a refresher. And sites like the American Heart Association, the American Lung Association, for those in pulmonary, these are good first stops for getting that understanding of what's actually happening, what kind of conditions are seen in that particular specialty. So that's a great way to kind of get yourself going and know that there are resources out there for you. But however long you stay in a particular specialty is really kind of up to your facility. Some facilities are very liberal when it comes to allowing the coders to learn other specialties. Some supervisors really love that because that helps them. They won't be caught with trying to like, oh my gosh, somebody's out for this particular clinic and we don't have anybody to cover because we don't have anybody trained for that. So if you want to really get a good grasp, I say a good grasp happens after a year in a specialty. But it doesn't mean that you can't simultaneously learn other specialties, right? So you're going to really understand like what's happening after 3 months, but the really good grasp of that specialty will happen after 1 year, okay? At least that's just been my experience in the whole thing, because there's things that you're going to be learning all the time. And again, the physicians that you work with, the nurse practitioners you work with, the PAs that you work with, those people are going to document differently, and they're going to have different trainings. They're going to have different ways of writing things down. So your knowledge base is going to grow and grow and grow. But you always want to make sure that you are open to trying different specialties. Now, I've talked about some specialties that are really great for new medical coders to start out in because you get a variety of everything. So the emergency department. Coding for the emergency department, you will see literally everything, okay? And you will code for major procedures, minor procedures, major procedures, because sometimes in the ER, they will apply a cast. Not always. Sometimes they just apply a splint if the person's coming in and they have like a fracture because they want ortho to take care of it. Ortho may have a different plan, or they may have to take that patient to surgery. The purpose of the ER, the point of the ER is to stop the bleed, right? They want to make sure that they stabilize the patient and the patient can go on to whatever specialty that, you know, they need to go to. So starting off at something like the ER is really going to give you a sampling of different specialty coding, right? And you still get evaluation and management practice as well. Sometimes you do, sometimes you don't. I've heard of some ERs that they rely heavily on the electronic health record. Sometimes they have a big electronic health record like Epic, and so they really depend on it to select the levels for them. I never believe in that because it's AI and it's computer and everything. You still have to have somebody looking at it, but you know. But for those of you that will code for the evaluation and management level for the ER. Again, it's great practice in getting leveling, okay? Now, the ER is the one that's not going to use like time-based, right? Because you can't do time-based in the ER. And there's no such thing as new patient versus established patient because everybody is the same, okay? Nobody goes to the ER for their follow-up care, or they're not supposed to. But so with that said, but you're still going to learn about the leveling. You're still going to learn about, okay, medical decision making and that kind of thing. So that, again, that's a very good place to start. You can get exposure to neuro, you know, if the person's coming in with stroke, cardio, person's coming in with a heart attack or chest pain, ortho, obviously, if they, you know, have broken bones, and anything else. Like there's a bunch of other specialties, you know, endocrine, there's a lot of different specialties that get seen in the ER. So that is a great place for anybody to start. And starting in the ER is going to make you a very strong coder because, again, you're getting exposure to everything, plus any of the procedures that are performed in the ER, like, you know, the splinting, the casting in some cases, hydration and that kind of thing. So there's a lot of things that are a good jumping off point for other specialties, right? Because you're going to see like EKGs also done. So when you go over to the cardio, if you decide to go over to cardio or you get assigned to the cardio clinic, then you're able to know, at least have some kind of foundation of, okay, I know what this means and I know what this language means and that kind of thing. Because again, it's a medical terminology is a huge, huge language. And because of this, we have to learn a lot. But again, starting off in the ER is really great for new medical coders. Starting off in professional fee is also really great for new medical coders. You'll sometimes see in the job ads pro fee, PRO-FEE, pro fee. Now I spell it out because I've had several people, what did she say? Pro fee, pro fee, which is professional fee. That is what is called in the industry, pro fee. And so the best way that I can describe it that's going to make sense, right, is the patient is staying in the hospital, right? Let's just say, for instance, internal medicine admitted the patient. This is a patient who's a diabetic and is in diabetic ketoacidosis, right? And there's a lot of things going on with this patient. The patient's blood sugars are all out of control. And as they're looking over the patient, they see that the patient has a wound on their foot, an ulcer. They notice an ulcer on their foot. So they call up podiatry and they say, hey, podiatry, we have a diabetic patient here who has a foot ulcer. Would you please come and look at this patient? The podiatrist says, sure, I'll be right there. So here comes Dr. Happy Feet up to the floor, and they greet the patient and they start to, look them over, and they start their evaluation. So that has to be paid for. That physician has to have their time paid for, which is, now we start going into the evaluation and management. This patient is on the floor. They're not walking into the clinic, which that would give like regular E&M. If it was a new patient, it would be like a 99202 to 99205. That's your new patients when you're in the clinic. But because we're going up to the floor, now we're looking at the evaluation and management levels for inpatients, which is 99221, 99222, 99223. Those are your initials, okay? They have initial, they have subsequent, and they have discharge E&Ms. So take a look at your evaluation and management section of your CPT book, so that way you can start to get familiar with what those codes are, what those evaluation and management codes are. And so anyway, this Dr. Happy Feet goes up and sees this patient, and they do their initial visit, and then when they continue to go up and see the patient and check on them in the subsequent days, you'll report the subsequent days E&M for the patient that's on the floor. And then when the provider discharges that patient, then you'll report the discharge code for that. Now, if you were coding for the inpatient side, right? So kind of compartmentalize what I just said. If you're coding for the inpatient side, inpatient meaning that your coding is for the facility side, because there's two people or two entities. There's an entity and a person that needs to be paid, okay? So the pro fee, professional fee, is the doctors. That's the doctors getting paid, right? Let's just make it simple. Doctors getting paid, right? And then we have inpatient, which is facility. So when a patient stays in a hospital, they are using a bed. They are using the staff that's used to take care of them. They have like the bandages and all the other good stuff that they have to take, like the special equipment and all that other good stuff that's used to take care of that patient. The facility needs to get paid. So that's inpatient coding. That's ICD-10 PCS, okay? That is something completely different from CPT. One has nothing to do with the other. These are two separate things. The inpatient procedure codes are ICD-10 PCS. If you are coding for professional fee, you do not have to worry about that. All of your codes that are going to be reported are coming from the CPT manual. Don't worry about anything ICD-10 PCS. But if you are coding for the facility, yes, you do have to do ICD-10 PCS. No, you do not have to worry about evaluation and management, because it's not a doctor that you're having to account for, right? It's just a facility, the usage of their rooms and their staff and that kind of thing. That's where ICD-10 PCS procedure codes come into play. And of course, the inpatient rules. But you'll know this by applying for a professional fee position. When I worked professional fee, I coded for every specialty. So it was sort of like how you get exposure with the ER to everything, it's the same idea with professional fee. Now, not all organizations will do their professional fee coders like that. I just happen to be one of those ones that you have to code everything blue. Everything from mother baby all the way to ICU. I had to code everything, okay? To include ortho and podiatry and all of those, internal medicine. I had to do all that professional fee work I had to do, which is fine because like I said, it still gave me exposure to those different specialties, okay? So I was in there, I was over there for 8 months at my other, where I came from before I got here. And that's how long I was there, but I was able to grasp it really quickly. So again, however long, it's going to be based on your facility and the facility's needs. When I got here, I was in Profi. I was immediately put into Profi because my experience was what got me the job here, you know, and I was able to do all of those things. So I stayed in Profi here I was in Profi for a year. Then I went over to behavioral health and I did TBI as well, traumatic brain injury. We have a particular specialty clinic for that. And so that's what I did. I did that for 6 months. Then I got moved to another supervisor, which was totally fine. So after that, I bounced around with that new supervisor. I bounced around. I did some PT and OT, physical therapy, occupational therapy. I did that. I did the pain clinic. I did same-day surgeries. So I kind of helped out wherever I was put. And so because I was already comfortable with different trains of thought, you know, with different specialties, it wasn't difficult for me because I'd already had exposure to multiple specialties, okay? So that's something that you'll know when it's time to move on, when it's time to like ask for a different assignment or ask to be cross-trained. You don't necessarily have to be moved out of that clinic, but you can ask to be cross-trained, okay? Asking to be cross-trained is a wonderful thing, and it makes you look really good on your evaluations as well. So just make sure that you're volunteering for that. You want to be somebody that does not have fear when it comes to coding certain things, okay? Or anything, really. Because you will see people that in the industry, coders, that will say, I don't code that. I don't do that. I don't like that. Do you think I like everything I have to code? Sometimes, no. Sometimes, no. It depends on the documentation, too. That also plays a big part of it. But because some of these, especially if the provider has not been trained on good documentation, it makes it even more difficult because now you're trying to decipher what the provider is trying to say. And then they're selecting codes and these codes don't fit. So then you've got to figure it out. So again, being really good with communication does help. But like I said, make sure that you're volunteering to be cross-trained, and so that way you can be proactive. Again, there is no prescribed amount of time that you need to be in a certain specialty to be considered an expert. No one will ever be expert level. You can have a lot of knowledge, but to be expert, I think you would have to know everything, and no one knows everything, not even me. Okay, so that's the thing that hopefully that kind of helps with this sort of question. And sometimes you may be moved out of a clinic even before you've really felt like you've grasped everything. So there's nothing wrong with it. It's just being open to trying other things and not saying, oh no, I don't do that, or I don't want to do that, that's too hard, right? You're in coding, okay? And as my former boss said once, when you have a certification, you are expected to know how to get yourself started in every single specialty because you have been tested and you've showed competence on every single specialty. So there's no excuse. And I couldn't agree more. There is no excuse for shying away from a challenge. And sometimes you just need a few days to start learning a specialty. But like I said, getting yourself familiar with the websites that are dedicated to those specialties, the American Heart Association, the American Lung Association, you can, the American, I think it's American Academy of Family Practitioners, they're really good for family practice medicine type articles. And so that's really good for you to kind of like check that out as well. So again, when you're filling out your resume, you can say all these different specialties that you know or that you've had experience in coding with, right? And so the more specialty experience that you can get, the better off you'll be, you know? But don't think of like, oh, like family practice, it's just family practice. Family practice sees everything. Well visits, colds, you know, sprains, you know, injuries, they see everything. So, you know, there's a lot to that too. And whenever you are filling out your resume, you want to make sure you don't just say family practice. Did they see geriatric patients there? Did they see pediatric patients there? Was it just woman visits? You know what I mean? Like, what was there? What did you code for when you were there? Okay, so yeah. But I can say for myself, because I've had all these different experiences with prophy, and then being in ortho. I've been in ortho for, let's see, we're in 2025. It's like 14 years, something like that. 14, I want to say 14 years I've been in ortho. But there was a time that I did get pulled out of ortho to go help in pulmonary and rheumatology and neurology. I had done neurology, that clinic, before, but they don't really see a lot of patients there, so it went off to somebody else, and then it came back to me. So I, you know, had to do my work there. But that's just, again, I can go anywhere because I'm not afraid of anything. And that's the way that you should be as a coder. Don't overthink this stuff, guys. This question is overthinking it. How long should I be there? There's no prescribed amount of time. Okay? Now, I will be more adamant when I say, like, for my risk adjustment coders, get out of there as soon as you can. 6 months, don't stay in risk adjustment coding or HCC, hierarchical condition category coding. Don't stay longer than 6 months, because you are not using your evaluation and management skill. You're not using your CPT skill. You're not using modifiers in risk adjustment. So that's why I say don't spend too much time there. It is very important. Risk adjustment is very important, but because people do not continue to practice evaluation and management, CPT, modifiers, they start to lose that. And then it diminishes your ability to be able to move on as quickly. I've gotten heartbreaking emails from people who said, Blue, I wish I would have found your channel 4 years ago, because I've been in HCC for 4 years and now I want to get out. Okay, well, what are you doing to get out of HCC? Well, I've been applying. Okay, but have you been working on your CPT? You know, do you want to do inpatient ICD-10 PCS? Have you been working on that? Well, no, I haven't done any of that. That's why I'm scared. Okay, well, then you need to get back on the book, because you learned it once, you can learn it again. Okay, you learned it once, you can learn it again. And that's what it takes, is for you to be like, okay, I know this is what I got to do. But like I say, in things that are going to limit your knowledge, you want to keep that to a minimum. The HCC, just keep it to a minimum. You know, some people are happy in HCC, but again, you're going to limit your opportunities to go places. You're going to limit your opportunity for growth as a coder, because you're scared and you only want to do diagnosis coding. And a lot of times what people don't understand is, to be really good at HCC, risk adjustment, you have to know pathophysiology. And I get emails all the time from people who code for HCC, don't have a lick of understanding about pathophysiology, unfortunately. And I tell them, you need to study pathophysiology. And You know, I mean, I can lead a horse to water, but I can't make it drink. Okay? I'm a Texan. We say things like that. It's not an insult. If you're insulted, this channel is probably not for you. Okay? So, but with that said, don't think too hard about it. Get into a specialty. If you're there, the opportunity presents itself for you to get cross-trained, by all means do it. Let your supervisor know, make your intentions clear that you want to be cross-trained, so that way you can have this experience and you can know like how you can help out with other specialties. That's just all I'm saying anyway. So with that said, I'm going to go ahead and wrap this one up. Thank you guys so much for joining me. If this video helped you, please like, subscribe, and share, and I'll see y'all next time. Bye.